Now it is my very distinct honor and privilege and very excited to introduce you to Dr. Ethan Russo. I'm going to guess all of you are familiar with who Dr. Russo is. He is a board certified neurologist, a psychopharmacology researcher, and the founder of his newest company, CReDO Science. Dr. Russo will share just a bit of his personal journey into medical cannabis, but my understanding it began in the 1990s when he was seeing in his clinical neurology practice that the medications that he was treating his patients with not only had some incredible harsh side effects, as well as they weren't efficacious. So he'll be sharing more about that. Dr. Russo is the Director of Research and Development for the International Cannabis and Cannabinoid Institute. That's referred to as the ICC. He was Medical Director of Biotech and 23 to 2014, he was a senior medical advisor, medical monitor, and study physician to GW Pharmaceuticals for numerous phase 1 to phase 3 clinical trials, which of course led to the founding of Sativex and Epidiolex. In 2011, I'm skipping over some years, but Dr. Russo published a landmark paper entitled Taming THC, Potential Cannabis Synergy and Phytocannabinoid-Terpenoid Entourage Effects. For 20 years, he's had faculty appointments in the pharmaceutical sciences at the University of Montana and in medicine at the University of Washington. He's the author of 7 books and has published more than 50 peer-reviewed articles. Dr. Russo received his medical degree from the University of Massachusetts. Dr. Russo's keynote, titled "New Frontiers in Cannabis and Endocannabinoid and the Endocannabinoid System." I've had the distinct privilege of previewing his keynote, which centers on Cannabinoid Hyperemesis Syndrome, or CHS, a study with focused on CHS, as well as another study focused on fibromyalgia. To give you some context about these 2 areas of need to treat patients, CHS is a puzzling syndrome in which chronic users of high THC develop an unusual complex symptoms, including severe cycles of nausea, vomiting, and abdominal pain. Currently, there's no definitive treatment for CHS other than recommendations for hot showers and applications of capsaicin, which is the active component of chili peppers. The rationale, as best as my understanding, is that the brain is essentially diverted away from the effects of THC by what is happening to the skin. Patients may be hospitalized, which of course is extremely expensive. Worldwide, 2 deaths have been reported due to CHS. The second study focuses on fibromyalgia, which is estimated to affect 2 to 8% of the world's population. That's incredible. And in countries where medical cannabis is available, that number is 22 million. The disease presents with increased sensitivity to extreme response to pain, as well as with sleep and mood disorders. So what we're going to be hearing from Dr. Russo are what are the study outcomes from Dr. Russo and his research clients. Does DNA play a role? What is the role of clinical cannabis for therapeutic benefit in both of these diseases and syndromes? So welcome to the forum, Dr. Russo.
Thank you, Jackie. And I'm going to share my screen. We'll get the presentation up. And I hope that's visible to all. Okay, I think we're set to go. So as mentioned, it's a pleasure to be here. And the title is New Frontiers in Cannabis and the Endocannabinoid System. You will see my email there if there are questions subsequently, and it's my understanding that everyone will receive a PDF of this presentation. Our first topic is Cannabinoid Hyperemesis Syndrome. This is a study that was undertaken with Endocanna Health as the ones that did the testing. I have a conflict of interest statement. Basically, there is a patent pending on the technology that we're going to describe in relation to possible diagnosis of cannabinoid hyperemesis syndrome. So, as we have heard briefly, this is an enigmatic syndrome. The first case actually was noted in 1996, but reported in 2004, actually in Australia, although this remains a disorder which is most prevalent in the USA. What they observed is what we observe today, even 25 years later, which this is a syndrome that appears in people who use chronic high-dose THC. And then they develop this unusual constellation that includes nausea, vomiting, abdominal pain, and then a characteristic behavior of taking hot showers or baths, which seem to relieve the symptoms temporarily, but this can become an obsessive kind of behavior. Abstinence from THC seems to be the only definitive treatment, but application of capsaicin into the skin may temporarily abort an attack. Some facts about this. The largest case series was at the Mayo Clinic with 98 patients back in 2012. There was a pretty thorough review in 2018 showing 105 journal citations covering hundreds of patients, but this disorder is becoming sufficiently prevalent that most doctors no longer report it. So we're not sure of the total number. Marika Devlono in 2020 published what I think is the best article on this subject and described 3 phases: prodrome of nausea and vomiting, anxiety and sweating, then a phase of hyperemesis, repetitive vomiting, accompanied by abdominal pain and the compulsive hot bathing, and then a phase of recovery following abstinence. Now, there have been a couple of studies that have looked at the cost per patient, but these are older. One estimate was $25,000, but the 2012 study by Perrotta noted a cost of $95,000 per patient for what was a diagnosis of exclusion, meaning that if you suspect CHS heretofore, a variety of tests would be done: scans, barium enemas, other GI workups, blood tests, and usually those come up blank. There have been 2 deaths due to complications of CHS that have been documented due to the repetitive vomiting and accompanying electrolyte abnormalities. Interestingly, standard antiemetics such as the serotonin type 3, ondansetron, granisetron, are poorly effective. Haloperidol and, as mentioned before, capsaicin seem to be better. A more recent article by Devlono, she had this nice chart showing the pathophysiology. So there have been theories about how this works. We know that cannabinoids can go through what is called a biphasic dose response curve. Everyone knows that THC and cannabis in low doses seem to benefit nausea and vomiting, such as in treating cancer chemotherapy. But at high doses, there may be a proemetic effect favoring vomiting by THC. So that biphasic nausea and vomiting response could be an explanation. We also know that with chronic use, there's a downregulation of the CB1 receptor where THC works. Also noted in this disorder is the activation of the hypothalamic pituitary axis related to stress responses from the pain, nausea, and vomiting. Also suggested in the past was a genetic predisposition, but this had not been categorically investigated. Patients with cannabinoid hyperemesis syndrome tend to be highly resistant to the idea that cannabis is the problem and not the solution to their symptoms. So there's been a prevalent myth that pesticides or neem exposure are the cause of this. In 2018, there was a study done in New York City at Bellevue, a very strange kind of methodology. They looked at people who were in the emergency department for other reasons, and then they queried them about their cannabis usage and whether they took hot showers. Now, they didn't use the standard definition of CHS, that I should say, but based on their survey and what is admittedly a different population than the rest of the country, they thought that as much as 33% of heavy cannabis users might have CHS. Extrapolating that to the US population, it would mean that 2.75 million people had cannabinoid hyperemesis syndrome. I suspect that that could be an overestimation. Looking at other data, there was an estimate of 350,000 in the US, but however you look at it, this is an emerging public health issue. This project was done with a hypothesis that cannabinoid hyperemesis syndrome could be related to mutations or single nucleotide polymorphisms called SNPs or other mutations in the genes that encode the CB1 receptor, which is called CNR1, or the TRPV1 receptor, where the capsaicin works? Or could it be related to the metabolism of THC with its metabolic enzymes? So the way to test this was with genomics. As mentioned, this was undertaken in partnership with Endocanna Health. We developed an extensive screening questionnaire to ascertain whether people had CHS or not. This all went through the usual channels, the Western Institutional Review Board, and recruitment began in October 2020, going for about a year. There were 585 total respondents to the survey. Now, we were extremely rigorous in who we would allow into what we call the CHS diagnostic group. So 205 of the 585 had all the cardinal symptoms of CHS. They had diagnosis by a professional, and they had ongoing symptoms. We did not want to include any people who might have been told they had CHS but didn't have symptoms now. Of the 205, 99 initially agreed to have their genetic testing done and were sent kits to do that, but only 28 returned them. This is where I need to mention that we had some very active resistance from online members of the CHS community to what we were doing. And there were various accusations hurled about us profiteering, not using the right entry criteria, etc. We also had 54 controls that were surveyed, and of those, 12 returned kits. Now, these were people who turned out to have heavy use of cannabis, comparable to the CHS patients, but lacked the symptoms. This is actually now the largest CHS study to date, with more than twice the number of the prior Mayo Clinic study. Now, I'm not going to go into this in detail, but standard genotyping procedures were followed. This is a very technical aspect. Although this is interesting, I really am not able to answer questions about this, except that this was standard operating procedure for genomic testing. Here is a survey summary. The 205 CHS patients were high-frequency users, 91% daily or greater than daily use of cannabis flower or concentrates. The median usage was 4 grams a day of THC predominant material. A high number had prior diagnoses of cannabis dependency or addiction, 15.6%, and over half had experienced withdrawal symptoms. Whereas the vast majority, almost 88%, improved after they ceased cannabis, almost all suffered recurrence rapidly if they resumed. Among the controls, 54, the use patterns were quite similar. 100% had used cannabis within a year, 70% daily or greater, mostly by smoking, again, THC predominant material. In contrast to the CHS patients, only 3.7 had historical labels of addiction or dependency, and 76% had never had withdrawal symptoms, and only 11% had problems for which they were told to stop for health reasons. If we look at the demographics, although most people believe that this is a predominantly male phenomenon, we had more females in both our groups. And this may be that women are more compliant with questionnaires. Can't say for sure. As you see, both were heavy users relative to what's expected. And in terms of abdominal symptoms reminiscent of CHS, none of the controls had these. This is a summary of the genomic testing and looking at various genes, which we're going to examine in detail. But this is all the information in one place, particularly for when you examine the PDF, you'll be able to see that. But we'll go over each of these. Now, one of our hypotheses was a problem with the CB1 receptor gene called CNR1. In prior studies, single nucleotide polymorphisms, or SNPs, were noted with cannabis usage patterns, but we did not see that in the CHS cohort. Now, this is an important finding because there is a condition called cyclic vomiting syndrome, which is mistaken oftentimes for CHS. Now, that is a form first of migraine, often appearing in childhood with episodic vomiting that later develops into headaches. Now, in cyclic vomiting syndrome, there have been mutations in the CNR1 gene that have been observed, but not in CHS. The first gene where we did see statistically significant differences was COMT, catechol-O-methyltransferase gene. So a mutation was noted with this assignation, RS4646316. Now that was seen in the intron, the introducing part of the gene, in 57.1% of the CHS patients, but only 10% of the controls. So that was a probability value of 0.12, which is considered pretty highly significant. What the function of this gene is to break down catecholamines, especially dopamine. When there's a loss of function in that gene, it can lead to excess dopamine. And this has been associated with things like compulsive behavior, substance abuse, gambling, and sex addiction. And that happens with drugs that have dopaminergic effects. And you see these things as side effects where they may not have been present before. This specific mutation was also in prior studies related to depression, rumination behavior, where you can't get something out of your head, and also a tendency towards heavy alcohol intake at a young age. Variants of this haplotype also have been associated with impulsivity, disinhibition behavior, attention deficit, obsessive compulsive disorder, anxiety, and psychosis. There's also been a relation to cognitive impairment by cannabis in people with this kind of mutation. So that's all very revealing. Next was the TRPV1. Now, as you'll recall, we had implicated problems with this gene. So a specific mutation was observed in 71.5% of the CHS patients, but only 30% of the controls, with a p-value, again, pretty significant, 0.015. TRPV1 has been linked to anxiety and pain responses in the brain. So there are receptors there, not just in the skin, not just in the gut, but in the brain. TRPV1 mediates long-term depression in the hippocampus. It also controls glutamate release in the solitary tract nucleus, which affects gut motility and secretion, so clearly relating to GI symptoms. Interestingly, in cannabis-dependent patients who were looked at genetically, they did not see TRPV1 polymorphisms there. So this seems to be a different animal. This specific mutation was not previously listed in the National Library of Medicine database, but clearly would seem to relate to the mood and gut disturbances in CHS, as well as the hot bathing behavior. And that could, again, help explain the efficacy of the cutaneous capsaicin treatment. I should mention that the capsaicin does get through the skin into the bloodstream and actually has higher bioavailability than oral usage, as when you eat hot food. The next gene examined was CYP2C9, one of the cytochrome P450 metabolizing enzymes. And here there was a homozygous mutation, so 2 copies in the intron of this gene, 46.4% of the CHS patients, only 10% of controls, with a yet significant p-value. CYP2C9 is the catabolic enzyme for various drugs, including arachidonic acid, precursor to anandamide, the endocannabinoid, and also for THC in its first metabolite, 11-hydroxy-THC, which is also psychoactive. So decreased function of this enzyme could lead to THC accumulation that would generate this biphasic dose response curve towards pro-emetic effects. And it's also possible, but not demonstrated, that there could be abnormal metabolites of THC that are produced. Dual mutation, along with another catabolic enzyme, CYP2C19, was reported in one patient who had cannabis dependency and personality disorder, as well as CHS. So we're beginning to see a thread here. A second dopaminergic gene is DRD2 that codes for the D2 receptor, which is the target of the antipsychotic drugs. Mutation was seen here in 60.7% of the CHS patients versus only 20% of controls, again, statistically significant. So drugs that stimulate this receptor are pro-emetic and also affect gut motility. This mutation is associated strongly with depression and anxiety in prior investigation. Other mutations on the same gene, distinct from this, have been associated with dependency on nicotine, Tourette's syndrome, and chronic pain. The combination of this mutation with that of COMT that breaks down the dopamine helps explain CHS symptoms, the nausea, vomiting, and these seemingly associated psychiatric sequelae. The next gene examined was what's called ABCA1, the ATP binding cassette transporter. Here, there was mutation seen in 67.9% of the CHS patients versus 20% of controls, again, highly statistically significant. This gene affects cholesterol and phospholipid homeostasis and has been associated with accumulation of abnormal protein products and A-beta deposition in Alzheimer's disease. So we are now worried about whether patients with CHS will have this genetic risk later in life, especially since we saw homozygous mutation, 2 copies. Additional risk factors with this profile would be coronary artery disease with heart attacks and development of type 2 diabetes mellitus. Polymorphisms in a related gene were associated with cannabis dependency, but that hadn't been reported yet for this particular mutation. So, in conclusion on this section, 5 mutations with plausible etiologic causative roles in phenomenology of cannabinoid hyperemesis syndrome were shown with statistical significance. We believe that this battery may represent a valid screening diagnostic for susceptibility to CHS. And if done early, it could obviate the need for repetitive fruitless tests and expenses. And taken from our publication, which is available open source on this topic, Cannabinoid Hyperemesis Syndrome can contemporaneously be conceived of not as a functional, meaning psychosomatic gastrointestinal disorder, but rather as a manifestation of gene-environment interaction in a rare genetic disease, unmasked by a toxic reaction to excessive THC exposure. So we'll move on to the second topic, and this relates to a study we've done on fibromyalgia, which we call the Fibromyalgia Autoantibody Study Project. Again, my email is there. Again, a conflict of interest statement. We have a patent pending on the technology involved in this presentation. But first, a little bit about fibromyalgia. This was first described by pioneering neurologist Sir William Gowers in 1904, called fibrositis. The name has changed over time. This is estimated to affect 2 to 8% of the worldwide population, and there are 10 million patients in the USA. The prevalence of fibromyalgia in countries where cannabis can be used is about 22 million. This remains a controversial diagnosis among some, but it is clear that it's the most frequent diagnosis seen by American rheumatologists and encompasses a constellation of musculoskeletal pain, sleep, and mood disturbances. Whereas some doctors still feel this is psychosomatic, it's been amply demonstrated that there's a central sensitization syndrome consistent with neuropathic pain, meaning that reactions to pain are exaggerated as compared to what one would expect. And this is in the absence of obvious persistent injury. There also is a secondary hyperalgesia, meaning that although the pain may focus in an area, say the shoulder girdle, people are extra sensitive to sensory stimuli, even in remote areas. This suggests disturbance in the glutamatergic system, the NMDA receptor, with a blockade that could counteract a defect in serotonergic analgesia, according to Italian researchers. Back in 1998, Richardson showed that hyperalgesia, this exaggerated response to pain, is related to central endocannabinoid hypofunction. We know that the endocannabinoids at the spinal level reduce this hyperalgesia, and this suggests the utility of cannabinoid treatment of disorders that affect this. And this includes allodynia, where a touch is interpreted as pain, visceral hyperalgesia, such as an irritable bowel syndrome, and conditions like reflex sympathetic dystrophy, complex regional pain syndrome. Cannabis is frequently used by patients with fibromyalgia, and we'll get into that more. Back in 2001, I developed a theory called clinical endocannabinoid deficiency. Basically, the hypothesis is we know that all humans have an underlying endocannabinoid tone that depends on levels of the endocannabinoids, anandamide and 2-arachidonoglycerol, how they're produced, whether they're broken down, the relative abundance and state of the cannabinoid receptors. The theory was that in certain people and conditions, whether born with this or acquired, endocannabinoid tone becomes too low and will produce these syndromes, often related to pain. And I published on this fairly extensively. The original long paper was in 2004. I focused on 3 disorders, which you see in red: migraine, fibromyalgia, and irritable bowel syndrome, but with other candidates. Interestingly, these conditions are comorbid, meaning that they tend to occur in the same individuals. So if somebody has chronic headaches, many of them will have fibromyalgia at some time. Similarly, there's crossover from the other conditions. What they have in common is they're all hyperalgesic states. None of them have diagnostic tests. They're clinically diagnosed. There's no characteristic tissue pathology or lab derangements. Now, if an unfortunate person tends to have all three, chances are that their male doctor will diagnose them as having a somatization disorder, and what we fervently believe is a biochemical derangement. There have been studies of this in relation to cannabis-based treatments. This one was done in Germany. Unfortunately, the ethics committee wouldn't let them use a control and only would let them use synthetic THC. So there were 9 patients. They tried to get them up to 15 milligrams of THC a day, which is too much for most people. And so they had 5 of the 9 drop out. Of the 4 who completed the study, there was no real change in allodynia or pinprick-induced hyperalgesia, but prominent reductions in perceived pain that was statistically significant. So if we look at that in graphic form, it would look like this. Pretty obvious that there was a difference, but again, not a controlled study. A study done in Canada looked at nabilone. For those not familiar, nabilone is a semi-synthetic THC analog. It is 10 times the potency of THC, probably a full agonist at the CB1 receptor. They looked at 40 fibromyalgia patients with 1 milligram nabilone BID equivalent to 20 milligrams of THC a day. Again, probably a relatively high dose. After 4 weeks, visual analog scales of pain, the Fibromyalgia Impact Questionnaire, and anxiety were all statistically significantly improved. Now, I'd point out that nabilone is approved in Canada and elsewhere for nausea associated with chemotherapy. It's never been approved for treatment of pain, of fibromyalgia, or anything else, although it is used in Canada because it's on the provincial formulary, whereas Sativex and Cannabis are not. Another study from Canada by Mark Ware looked at sleep in fibromyalgia, comparing nabilone again with amitriptyline. Nabilone was superior for sleep on an insomnia severity index, but there was no real effect on pain, mood, or quality of life. I just point out that nabilone, again, is not the best tolerated drug and is different from cannabis. Now, looking at cannabis, this was a very interesting survey done by the National Pain Report some years ago. So big investigation, 1,300 fibromyalgia patients. They asked them about their experience with duloxetine, milnacipran, and pregabalin, the 3 FDA-approved drugs for fibromyalgia. Their impressions, given the red that you see on the left side, is that these drugs didn't help at all or were really effective for very small minorities. Compared to cannabis on the right, where over 60% found cannabis very effective for their fibromyalgia and very few didn't gain any benefit. So we've got a severe mismatch here between the FDA-approved drugs and the still illegal cannabis. There has been one randomized controlled trial of a cannabis-based preparation in fibromyalgia, and this came out last year. So there were 17 women over 8 weeks with a THC predominant oil, looking at the Fibromyalgia Impact Questionnaire. Mean dose in treated patients was 4 milligrams of THC and 0.08 milligrams of CBD. There were improvements in feeling good, pain, able to do work, and fatigue. But actually, the placebo group was better on depression. There was no benefit on anxiety. Seemingly, this is low dosing. There were significant adverse events with somnolence, dizziness, and dry mouth. I think that this is probably a suboptimized preparation and would be a little bit different than what was seen in the survey, but still suggestive of a role there. So this led to the study that we're going to discuss, which I will point out we do not have the answer today, but I was fascinated by this book called Brain on Fire. We know that various autoimmune diseases affect neurotransmitter receptors. The obvious one is acetylcholine and myasthenia gravis, but also the NMDA receptor in what's called anti-NMDA receptor antibody encephalitis, which is what affected this young lady who wrote a book about her journey, initially being diagnosed as psychotic and then only recognized to have an autoimmune condition, which was successfully treated. So I thought that a similar phenomenon could affect the CB1 or CB2 receptors in fibromyalgia. If this were the case, it might explain the symptom complex with pain, the hyperalgesia, the sleep disturbance, anxiety, and depression, because all of these are mediated by the endocannabinoid system. What we did is look at 200 subjects, 100 with fibromyalgia and 100 who were controls. And this was done in the province of Quebec. We used the usual exclusion criteria, pregnant or breastfeeding, known autoimmune disorders, patients with severe endocannabinoid deficiency disorders. Everyone had to meet the American College of Rheumatology revised 2010 criteria for fibromyalgia, etc. And this is just a form that shows what is examined. In the first form, they outline areas of pain in the prior week, and then a total is taken of the number of affected body areas. And then there's a rating of the severity of fatigue, sleep disturbance, and cognitive symptoms. Then there are sums made of the widespread pain index score and the symptom severity score. Is fibromyalgia if the WPI is greater than 7 and SS greater than 5, or as you see, this variation, especially if there are no other conditions that explain the pain. So everyone in the study, all 200, went through this. The blood taken from these patients, both the FM patients and the controls, has been sent to Indiana University, where they're going to undergo studies to see if there are antibodies present to the CB1 or CB2 receptors. And this is done with these nice fluorescent photos, et cetera. And you see the methodology on the left, which we're not going to bore you with. We hope to publish this eventually. As I said, we don't have the answer yet, but we have strong suspicion that we could be right. And that's because of this study that came out a few weeks ago. What they did is they took immunoglobulin G from 8 fibromyalgia patients. And as compared to controls, when these were injected into mice, the controls didn't produce any change. But the FM serum produced mechanical hypersensitivity. 7 of 8 FM sera produced noxious cold sensitivity. The FM serum reduced grip strength in the mice and their locomotion. There were also effects on pain fibers, the A delta and C nociceptors. And this was there was reduced force to mechanical stimulation. Now, what this seemed to demonstrate that there was a humoral transferable factor in fibromyalgia, that you could get it from the blood of someone with it. This is exactly what we're purporting, but we are hypothesizing that the target is a CB1 receptor. So watch this space. We hope to have an answer soon and hope to publish one way or the other. Now, let's suppose we're right, that there are anti-cannabinoid receptor antibodies in fibromyalgia. If that's the case, then it would show that fibromyalgia is not psychosomatic and it has a biochemical basis. For the first time, there would be a laboratory test to evaluate the condition. This would have obvious commercial implications. These autoantibodies, their presence would perhaps allow cost savings on other tests that would not show anything. It also would legitimize a cannabis-based treatment for FM symptoms, and also raise the possibility of immunomodulation with other components of cannabis, such as cannabidiol and tetrahydrocannabinolic acid. It also could provide a basis for development of a biological. So this would be anti-autoantibody agents, such as are used in other disorders. And I want to close with a quotation from the 2004 article. Only time and the scientific method will ascertain whether a new paradigm is applicable to human physiology and treatment of its derangements. Our insight into these possibilities is dependent on the contribution of one unique healing plant. For clinical cannabis has become a therapeutic compass to what modern medicine fails to cure. Thank you, and I hope that we'll have some questions. And I will stop sharing the screen. Jackie, you're muted.
Yeah, thank you. Just unmuted. Thank you so much, Dr. Russo. Very fascinating. I do have some questions that I'll be calling on you to come on screen. But I do have two questions immediately. We're hearing a lot about the THC, how it is bred to be so high. Is there any correlation with the THC that's in market now with with these increase in hyperemesis syndrome?
Sure. Well, it is clear that the percentage of available THC, the average amount, is increased over time. Yeah, it really increases the risk of CHS for those people who are susceptible. Mm-hmm. Absolutely. And particularly with concentrates, we know that these are much more subject to the development of tolerance, and people will use more and more to try and attain their desired level of high. So the risk increases. It's a good bet that the prevalence of CHS has increased and could be related to this. However, again, to be fair, 2 points I'd like to make. Number one, not everyone is at risk. There are clearly people who are more at risk than others, seemingly due to this genetic susceptibility. Second, we need to make a distinction between this kind of adult use, or what's called recreational use, and therapeutic use to treat a disorder. There's a tremendous difference in intent and dosing. The dosing for treating medical conditions tends to be very much lower than so-called recreational doses. I am aware of only rarely where a medical patient has developed CHS. So there is a dose triggering effect, but when someone's susceptible and has developed symptoms, their ability to tolerate any amount of THC seems to go out the window, unfortunately. It remains to be seen whether other cannabis components without THC could benefit the condition. But for right now, our advice is abstinence is the best policy for those who are unfortunately affected.
Another question that came to mind, everybody will be getting the study emailed to them. So I'm fortunate enough to sit with the study right next to me. And I was looking at the mean age where it's what about 30, 33? And wondering if we're at the point yet with recreational use that, of course, the recommendation is that pregnant women do not use cannabis. And that could there be any correlation with a mutation if that did you consider that if the mother if there was a history known? Of course, this would be have to be self-reported, obviously, but any correlation there?
I don't believe so. And the reason would be that there's been extensive testing of cannabis and components for genetic mutation, production of genetic mutations. And this is simply not an issue, particularly at conventional doses. So people should not say Dr. Russo recommended cannabis use in pregnancy. I do think it has a place when really needed, such as hyperemesis gravidarum. But the idea of creating CHS susceptibility due to cannabis use in pregnancy, I don't think is likely at all.
Okay. All right. Well, I'm going to, and forgive me, I'm going to do my best to correctly pronounce your name, Gaetano. If you would care to come on and ask your question directly to Dr. Russo. His question.
You should be able to unmute Gaetano. Jackie, I go ahead and ask.
Yeah, I'll ask a question. Question from him is, did the cannabis change the genes, or did the genes change due to cannabis use?
What I'm going to say is we have every indication people were born this way. So there's an innate susceptibility. We have no reason to think what cannabinoids can affect gene transcription, but they're not changing the DNA itself. So let's be really clear on that. So yeah, you can gene expression can be influenced by cannabis as well as many other drugs. But no, we're not creating mutations through cannabis usage.
Okay. David Lanzalone, forgive me again if you care to unmute yourself and ask your question directly to Dr. Russo.
And
it
David,
won't let you unmute, okay?
It won't let you unmute, okay.
Probably be better to just ask the questions.
Yeah, I think we're going to be eating up time. His question is, have these results in fibromyalgia pain also, have they been found with CBD? Or is the THC necessary for these effects?
CBD alone doesn't seem to be adequate for treatment. This is an instance where at least a little THC seems to be necessary for a good clinical response in fibromyalgia, particularly on the sleep disturbance aspect. CBD alone, contrary to what some people think, is not a sleep aid. It could reduce anxiety interfering with sleep, but it is not producing sedation at low or moderate doses.
Okay, thank you. We're going to try one more time. Faye Berger Mitchell, if you're available to unmute and ask your question.
Hi there, can you hear me?
Yes.
Okay, great, thank you. I was just curious, I've also been doing some research into CHS this past year. I'm an MCST student of the current graduating year. Have you seen any correlation with patients with a history of either IBD or IBS or other GI conditions, or is it more of a chicken and the egg kind of syndrome? Are the people who have these GI conditions using cannabis to help their symptoms, and then they're creating this tolerance and getting into these higher levels of THC and developing CHS?
Yeah, the latter is distinctly possible. So in other words, if someone had a medical reason for taking cannabis, it could unmask a CHS response susceptibility. But again, Until recently, I wasn't aware of any medical users that developed this. I since have become aware of some, but it seems to be a distinct minority. And again, what we see is that usually, most often, people have to be using chronically in a high amount, have developed tolerance for this to be expressed. But again, the susceptibility may be there. It's even possible in the future that if a person had CHS in the family, that siblings might have similar risk and want to undergo the screening, even if they hadn't had it, prior to initiating use of high THC preparations. That's possible.
Thank you. Yes, I do feel like these higher THC products are what's sort of driving some of this with people who were using it medically, but then they're getting these higher THC products.
Sure. And let's just say at this point, most conditions that are responsive to cannabis-based treatments only require low dosage. Now, the exceptions are primary treatment of cancer, where sometimes hundreds of milligrams seem to be necessary, and then use of CBD as an isolate, as an Epidiolex, where very elevated doses are needed. Now, we have no indication at all that CBD triggers CHS. But again, most medical users require very low doses and hopefully will not have a high risk for development of CHS. And again, not everyone is susceptible.
Right.
Thank you so much.
Thank you, Faye. Question. We have time for one more question. Min An, if you're available to ask your question of Dr. Russo.
Yeah, so I guess my question is, this might seem counterintuitive. I actually put it in the chat, but in terms of the treatment of CHS in like an ER, would a fast-acting THC as like a one-time dose be a treatment to potentially stop symptoms associated with CHS? No? Okay.
No, that's exactly what the affected patients are doing. They're nauseated. Everybody knows that THC is good for nausea, and so they're trying to treat it by using the thing that's making them sick. It's really unfortunate. And again, I cannot emphasize enough the kind of resistance that patients have to the idea that cannabis is what's causing the problem. And this has led to vociferous disagreements online and, as mentioned, active resistance of what we were trying to do in this study.
Great, thank you.
Well, thank you. And that wraps up the keynote and our time with Dr. Russo. Again, thank you so much for presenting the two studies. And again, everybody is going to receive a PDF of the studies along with his email address. So you'll be able to communicate directly. One of the things about Dr. Russo, he is well known for making himself quite available to those of us that are so collectively moving the industry forward. So again, thank you, Dr. Russo, for the generosity of your time today. And I know it was a very early morning for you in Montana. So enjoy your day.
Great. Thank you.
Thank you.
It's gonna light up.